Academy mentoring. Challenging cases, extending and deepening your resources, lifetime learning. My take on this month's questions. So, part one, we talked about learning from your patients. We talked about having interesting or challenging diagnoses that we may see a lot more of than any one physician. We talked about actually pattern recognition in that and proactively looking out for patients that may not have a great diagnosis, that may need a better diagnosis. We talked about having conversations with physicians to learn more about particular diagnoses or problems with our patients. So in this week, we're going to spend a little more time on building the relationship and managing the relationship with physicians. And for me, the one thing that I want to state up front and get out of the way is you are a prosthetist orthotist. You are a specialist. Your docs don't know what you know. And it's really important to, when you come to the relationships with your physicians, to approach them with equal stature. So we're going to talk about a few particular cases that I'm going to say are pretty common to our field, where you need to step up your game and tell the doc how it's done. And in navigating that, I hope to give you insights in how to manage and handle physicians and how to develop relationships with them where they really do see you as a partner in the medical team. So I'm going to start with three things that I'd like to talk about that I think, no, I'll make it four, do one orthotic one, that I think are essential for us as orthotist prosthetists to be well representing our field and what we know so people get better results. And those are going to be Charcot joint, amputation length, and Van Ness procedure and Symes. They're going to be bundled together just a little bit. So here's why I want to talk about that. Let's start with Charcot joint. If you're fortunate, maybe you live in an urban environment where there are excellent specialists managing active Charcot joint. More likely, you have people that don't know how to appropriately manage Charcot joint. They might have a diagnosis for a patient, but that patient isn't being immobilized while the active portion of that Charcot stops. And that's so crucial to saving someone's foot before it becomes an ugly mess. So I wanted to start here because I have worked with fantastic physicians that really knew their stuff and did serial casting until the joint was no longer active Charcot, and then orthotic treatment after that. I've worked with fantastic physicians that it was a serial cast or a cast until we could get the Charcot boot for the patient, and then well managed in a Charcot boot. But it's much more common for us to see a patient where they have a developing foot deformity, they have some problem, they've been referred to an orthotist for some type of intervention, and most often that might be a prescription for like a foot orthosis or a shoe. And you use your diagnostic power, temperature, and determine that, whoa, hold on, this joint's hot. This is an active case. where the bone is remodeling, and we can have a much better outcome and impact if we have immobilization of the joint. So this isn't the case that these are people that willfully don't know what they're doing. It's they don't see it enough to know what to do, but we do. So at these junctures, it is appropriate to go to your physicians, to speak with your physicians, to advocate to get a Charcot boot for the patient as opposed to just treatment with the shoe, to have the discussion about, hey, that appears to be an active Charcot right now, and are you familiar with how immobilizing can get us better outcomes? It can prevent the deformities that follow, and you can take better care of your patients, might get much less likely that they wind up with an ulceration because you protect the structure of their foot. So this is a great conversation to have. I didn't say it would be easy, but a lot of the not easy is probably just in your head. You are an expert. You do know what you're doing. You do know the right course of action. You do know what's best for the patient. And it is completely appropriate to take that authority and that knowledge and have the conversations with people who happen to be doctors that don't necessarily know all that stuff. So just build up the courage to have the conversation. Now, a couple little strategies that we always talk about good communications. We talk about it as being an upfront contract, and there's 5 elements: the time, the agenda, what's your role, what's my role, what's the clear path forward. So let me put how an invitation to a conversation with a physician would look in the context of those 5 elements. We're going to start the conversation with the physician's nurse. Carol, I just got done seeing Jim Doe, and my concern is that he has active Charcot and his joint should be immobilized. Might I have 10 minutes of the doctor's time to discover if he's familiar with current treatment for active Charcot and the difference in the diagnosis of it? And during that time, I'd love to answer questions if he has any. And at the end of that time, I'd just like to know if we can move forward with an orthosis that would provide more immobilization for this active Charcot joint now. And no's okay if he just wants an insert for the moment. So by having that conversation, you've set times, you've made it clear what you're looking for and what you're after and what the path forward would be. And usually if you do that, it's fairly easy to get a conversation with the physician, or he might even turn around and say to his nurse, Carol, hey, Carol, man, let John do what he wants. Tell him to send over what he needs as far as a prescription. I'm glad he's looking out for our patients, and I'd love to learn more of what I should be looking for, so I send him the right thing. So it might not even wind up being a conversation with the doctor, but thinking about it in that upfront contract way, talking about time, your role, my role, what's the agenda, what's the clear path forward, will just let you have positive, focused communication with your physicians when it comes to these things. I got some bad news. There's going to be some set in their way physicians that think of you as the shoe guy and really don't care what your opinion is on anything, no matter how right it might be. And that's okay. maybe over years of time you can change their minds, or maybe they'll be out of practice before you have to worry about changing their minds. But that's not the norm. Most even seasoned physicians understand they're not experts in everything and are ready and willing and able to listen to you when you come with our specialized solutions. So build up the courage and be willing to have these conversations. Now, I want to go through the other ones. So amputation length. I love this because I usually tell this to my residents and they don't believe me until they stumble upon it. And this is how they usually stumble upon it. You know, we'll have a patient that we've been caring for that needs to have an amputation of their foot, and I make sure that we well represent the type of length that we'd like to see when it comes to that amputation so that they get the best function out of a prosthesis. Now, sometimes it's limited by their vascularization, but this is the way a lot of doctors are instructed to measure. Yeah, 4 fingers down from the mid-patella tendon and cut it off. I dare say that's a really crappy amputation if you have a well-vascularized leg. You're giving them a really short lever arm, especially if you don't have hands as big as me. And I laugh about it because, yes, physicians are still being instructed to do that in school. Yes, they still learn that from other physicians. No, there isn't any good standardization that says this should be the length that's well documented and instructed. So if you are caring for an amputee, or excuse me, if you're caring for someone who's moving towards being an amputee, make sure you have the conversations with the physician so that you don't get one that long. And if you have a physician that's sending you patients and they all seem to be that long, that's short, that's not good. Have the conversation with the doc. Hey doc, is there a particular reason why you're doing short amputations? Is it something we can discuss? I'd love to see some of your patients have a little bit longer amputation as long as they have the vascularization to support that. So another place where we are the experts, this isn't well understood, go represent and make a difference for your patients. The remaining 2 here fall under opinion a little bit more, but I have a strong one. So, Symes amputation and Van Ness procedures. Now, let me tell you a little of the reason why I have a strong opinion. Because I've been doing this a very long time, I've seen lots of both, and you don't get great outcomes with them. When it comes to Symes amputations, the prosthetic componentry that we have nowadays, just the good stuff doesn't fit under a Symes amputation. And the reason for a Symes amputation is generally explained as, oh, well, it keeps their fat pad, they can actually distal end bear, they can get around without a prosthesis. The reality is that's not really the case. And the literature that supports that is like 70 years old and hasn't been updated. But it's still what physicians will reach for if they're wondering. So they may be doing a Symes amputation. So if you have a physician that's doing Symes amputations, have that conversation. Go to the physicians. Show them the difference in componentry if we can get a little higher. Explain that, yeah, that fat pad's going to migrate. No, it's not really something most people can walk on. And yeah, if they had a higher amputation level, they'd be able to take advantage of a lot better current technology. The Van Ness is like this. I'm going to say it's a little more politically challenged. But I've had so many patients that had a Van Ness and went on to have a secondary amputation with the removal of the foot from the Van Ness procedure so that they could be fit as a regular transfemoral patient, that I do feel strongly about this. If part of the problem here is Van Ness is sort of a sexy surgery. It's like, oh wow, we can do all this stuff, and you get all this motion, and it's a neat surgery, and now we can use the ankle as the knee, and it's cool. But on the prosthetic side of things, you then have a knee that's not fantastic. You have weight-bearing surfaces of the foot, but never can they fully weight bear just on the foot. And you have ancient tech available then, because you have to do outside joints. So you don't have a modern prosthetic knee. Frequently, you even have to go up to the ischium ramus to help unload the foot. So you're either some type of knee bracey thing or joints and corset thing, outside joints, a real funky shape that's challenging to fit, and can they volitionally move their knee? Sure, limitedly. So given the opportunity, if there's a physician whom is doing Van Ness and it doesn't seem to be like their whiz-bang specialty, they're another physician that I'll try to have that conversation with and see if we can move towards getting much simpler amputations where those patients can be fit with modern prosthetic componentry at the knee and at the foot. Now, other tips and tricks when it comes to helping the conversation with your physicians. Do take advantage of their staff. Physician offices are very different than O&P offices. They're getting hit all the time by sales types. And you're not a sales type. And you don't want to be seen that way. So yeah, if you're going to the office, wear the white coat. When you're speaking with their staff, have it be about a particular patient. When you might just be dropping by, be thoughtful about, okay, so who are the common patients that I've been working with, so we can talk about that as I'm just saying hello. Do be respectful of the physician's time management. Most certainly they're going to have a nurse or administrator that fields the questions for them and sets things up, and so build your relationship with them so that they can set you up to have the conversation with the physician, so that they can communicate between you and the physician, so you can get your answers, your questions answered. And as you do this over time, just work that relationship so that you are a respected part and you are their advisor of record when it comes to orthotics and prosthetics. They know they can count on you to be informed and provide good answers for them in an area of specialty that's not their own. So I'd like you to remember that when it comes to building relationships with physicians, most of your problems here, that they're human too, and you are an expert at what you do, and that's where you want to make sure you are communicating with them. I hope this helps as you build your deep expertise, as you build your resources of knowledge, and as you take seriously lifelong learning when it comes to your profession. Thanks.